This is the final session. It really is a town hall type meeting. There really is these, now the floor's all yours, has been all yours all couple of days, but really is the chance to ask questions around anything you've seen through the conference or anything that's, you may have talked to somebody, you've got this little question that's niggling at you, you want to ask it. Let's quickly introduce the panel and their roles so you know who we've got. So let's start at the top with Bookie.
My name is Dr. Olubukola Ayodele. I'm a consultant medical oncologist.
Donna Murray, breast care nurse for 30 years and no more. Till this year.
Jill Bishop, I'm a clinical oncologist.
Sheetal Sharma, I'm a breast radiologist here in Liverpool.
Lesley Stephen, patient advocate.
Marina Parton, breast medical oncologist.
Matt Rowland, oncoplastic breast surgeon and breast sarcoma surgeon.
So does anybody from the floor want to open us up? It's a bit like an auction. Who's going to go first? Do I have any bidders? Okay, let's go to the lady there in red, I think. And then we'll take some questions from the Slido. We've got one question.
I don't want to frighten people in the room, but how common is skin metastases? I'm triple negative, and how do you treat them if surgery are running away and saying no?
Bookie, one for you.
Yes. So it's really interesting that you said triple negative because that's where we actually see a lot of skin metastases. It depends on the number and where the skin metastases. So if it's multiple, where it's covering a lot of areas in the body, then we tend to treat it with what we call systemic therapy, so drugs. If it's one area, then potentially we could ask our clinical oncology colleagues sometimes whether radiotherapy could be a potential way to do that. There's some places where you have this electricity targeted treatments that happen, but it's not available everywhere, but that's also a potential. But generally it depends on how many, where it is, and what you've had before to treat it.
Jill, do you want to just talk briefly about electron therapy for skin mets?
I'll happily talk about electron therapy for skin mets. So
briefly.
Electrons are particles, come out of do you remember the linear accelerator we talked about earlier today? And they have a very characteristic profile, which means that they stop a very short distance into skin, so they are into tissue, so they are really, really good for treating superficial lesions.
Yes,
and if you've got just a small number, then it's actually very reasonable to give radiotherapy, particularly if you've got disease controlled elsewhere, so you've got what I call oligoprogression.
Marina quite rightly reminds me about electrochemotherapy. It sometimes comes up. Evidence base is sort of, not robust. Matt, do you want us to talk briefly about that? Because have you heard about electrochemotherapy?
Yeah, it's too big an area.
So, Matt, do you want to explain, Matt, what electrochemotherapy is, and maybe when we think about it, because that's a very individual decision, because it's the evidence base isn't very broad or strong.
It's not available everywhere. Certainly in this region, it's run by our skin cancer plastic surgeons. I have done it previously when I worked in Exeter as a fellow. In essence, the patient has to have a general anaesthetic, so they need to be relatively fit. And during the anaesthetic, they have an infusion of one of the chemotherapy agents called bleomycin, and the probe has multiple needles, and so those multiple needles go through the skin into the tissue, and electricity is passed through. And don't ask me how, but the electricity makes the cell absorb the bleomycin chemotherapy. The issue is that obviously it makes the tissue worse before it gets better, because it gets inflamed from the process and then from the chemotherapy breaking down cells. So you have to often get people's pain controlled beforehand, much stronger painkillers for afterwards, including often neuropathic, so nerve painkillers. So it's not an easy process, and if it's on a big area, I can see why people would be cautious. So it has a role. It's fairly niche in breast metastases.
So I've got a question for Sheetal from audience online. The role of mammograms in metastatic breast cancer. Should we be doing them? When should we be doing them? Should we not be doing them?
That's a very good question. Excuse me. I think it depends a little bit on the prognosis and the plan for the individual patient. So we don't have a blanket rule that we don't do them at all in metastatic patients or that we do them in all of them. It depends a lot on the extent of metastatic disease. If they are really well controlled, bone metastases, for example, and no other metastases, there is a role potentially to still follow up the breasts as we would after a non-metastatic breast cancer, and we tend to do annual mammograms for a number of years. So there isn't a blanket answer to that. But I think if it's someone in whom we wouldn't consider treating something in the breast because of the degree of their metastatic disease, then why go through the process of bringing them, radiating the breast, and the anxiety waiting for those results if we're not going to act upon them? And that's true of a lot of the tests that we do. From a radiology perspective, all the investigations that we do, we want there to be a reason to do them because we want to know that we're going to act on what they show us. So those are the cases where you might stop doing those mammograms if the extent of other disease is going to take precedent, if you like, over anything new that we might find in the breast, because you can end up finding incidental things that we go down a long road. You'll have all been through biopsies, and we found a small area of calcium, for example, and then we've investigated that over and over again. We bring you back, we do a different type of biopsy, and we only want to be doing those things if it's going to alter what we do with the results of them.
Sorry, I was
Marina?
just going to say dead quick that information needs to be relayed to you, not just you phoning up saying I'm due my mammogram in July and we say, oh, actually you've got metastatic disease, you're not having them anymore, bye. So I think it's how that information is relayed is the reassurance that you're getting as to why you're not having them. Sorry.
No, you're absolutely right. Absolutely right.
And I was just going to mention that with whole body imaging, which many would be having every 3 to 6 months, the axilla are always looked at. And although the breast tissue is not perfectly seen, it is still seen. So I think if there was any gross abnormality, that would be picked up.
And
that's
obviously
really
some
what
people
we're looking for. It's those gross changes, and we would tend to see those on a CT scan or a PET scan. What you wouldn't see is the 2 and 3 millimetres of calcium, but we're probably less bothered about those anyway because we don't want to start down that route of investigating tiny changes. We want to know if there's something significant that's going to alter
if a
what we
patient's
do.
de novo and still has the lump there, we should be monitoring that with ultrasound just to make sure it's responding like any other bit of the body.
Yeah.
So, Marina, I've got a question for you. If anybody's got a question, please put your hand up. Let's take a question from the audience. Lady in the green cardigan or a top. Pop, I think, or pop. Pop.
I've got a question about lymphedema. How can we best prevent it? Who's most at risk?
And Matt and Donna.
And what is it that actually causes it, please?
Well, I'm going to start with that first bit. We don't really know why people develop lymphedema and why some do and some don't. Clearly, the more we do in terms of the more surgery and the more radiotherapy, the risk goes up. So we think that it's something to do with trauma or inflammation to the lymphatic vessels means that over time you end up with poorer lymphatic drainage. So the people who are most at risk are people that have had either more extensive tumour in the lymph nodes in their axilla, have had more extensive surgery, and or have had radiotherapy covering that area. In terms of what you can do to prevent it, there's no clear prevention other than we say try and reduce the risk of further inflammation and infection into those draining lymph nodes, which is why we would prefer that people use your other arm for cannulas and injections. In reality, that risk is very, very small, particularly from, say, a blood sample. What we'd be more worried about is having a long-term drip in there where a drug or chemical that's irritative is repeatedly being infused up there. But in an emergency, I would prefer that another doctor or a healthcare professional, paramedic, just gets access to your venous system and gives you the drugs that you need for infection, etc., and they swap it to another site at the earliest opportunity. If you have lymphedema, I'm not going to go into the treatments, but you should be able to get good quality information by a trained practitioner. I know there is often a waiting list, and they'll give you honest, evidence-based advice. There's a lot of stuff that is myth and speculation. Donna, do you want to say anything from a breast care perspective?
No, just reiterating that really, but also the access to lymphedema. Sometimes, I think we spoke on Monday about hospices, or yesterday, sorry, and a lot of our lymphedema services are set within community settings within the hospice, so don't be scared if you've got lymphedema and we're referring you to a hospice. It is just for that symptom management.
And that's a big issue, actually, is services for lymphedema are pretty sparse and not many. There's often a waiting list, as many of you would have probably experienced in your trying to get hold of lymphedema services, so it's a real challenge. I'm going to take a question online first while the mic goes there. This is for Marina. It's about subtypes of breast cancer. The question essentially is, do you think we'll subtype further? Example, androgen receptor, different subtypes of triple negative. So do you think we will see further sub-classification of breast cancer based on treatments?
Yeah, so thank you very much. I think we will see definitely further subclassification. It's just the nature of things that as we get more information, we know that when we see someone with triple negative breast cancer in the clinic, the trajectory can be very different, very different. And so when we give broad prognoses, that's exactly what it is. Some people will have very rapidly aggressive disease that requires the stronger treatments as soon as possible, whereas others will have a more indolent disease that will change over time. And we need to be able to differentiate that to tailor the treatment. And I think Jill and Bucky can potentially add to that. There is no doubt that we will subclassify further.
Yeah, absolutely. So triple negative breast cancer right now, we found out there are about 6 subtypes, and we're still finding out more. So it's really important that when we speak to you, sometimes we just generalize, and sometimes we don't know where you fall in. I think the easiest one that we know right now is when you have PD-L1 positive, which means that you're sensitive to immunotherapy. I think that's the most common one. But another one coming up is the androgen receptor.
And in ER-positive disease, we look for the male sex hormone receptor, the androgen receptor. There's a study open at the moment where we're looking for women who are AR-positive. About 80-90% of women with hormone-positive cancer express the male sex hormone receptor, the androgen receptor. That's a therapeutic target. So even in ER-positive disease, we may see further receptors being added in as research develops and we get the targets. Question at the back.
Hi, there's been a lot of news recently about, is it histosonics coming into, is it Cambridge? So it's to do with liver lesions, so it's a new kind of ultrasound that they use to target liver lesions. I think it's called histosonics.
Okay. So, yeah. So,
histotripsy, sorry, wrong name. So obviously I think it's just been approved for Europe, and I think it's coming into Cambridge, so just wondering what the panel's views are, if any.
Let me just make the point that we do already do ultrasound ablation, so maybe Marina and Sheetal. I don't know about that specific company or that specific technique, but we do ablate already. Maybe Sheetal, because that's of interventional radiology.
Yeah, I mean, I'll be honest, I don't know anything about that, so I'm not going to give you any sort of informed information about it, but yeah, we certainly do a lot of ultrasound-guided techniques and procedures. So ablations are obviously, there's lots of ways to ablate, and predominantly it's all radiation that we use, or radiofrequency in this country. But that sounds interesting, and I'm definitely going to go away and read more about it. But I don't know the specifics of it, so I don't want to give you false information or slightly made-up information. I don't know if Marina knows more.
Yeah, I mean, the other thing to bear in mind is that you often see stuff in the press, and you get this company. Remember, companies need to make money. So sometimes people will approach, companies have press officers. Their job is to get PR for companies. So sometimes when you read stuff in the press, it's not really new. Sheetal just told us that we can ablate liver mets, and I've sent a number of my patients for ablation of lung and liver mets. I've got very good, at the Royal where Sheetal works, very, very good interventional radiologist, as probably has Bucky and Marina, who can insert probes and ablate mets. This company probably is doing something similar. Maybe they've got a new box new box of tricks. But actually, it may not be that different to what we've got now. So always ask yourself when you read something, is this really new? What's behind the article? It's a company. So just sometimes you know, we need sometimes to think about what we read about, but...
And just to add that, you know, the adage that more isn't necessarily better, new isn't always necessarily better, but new innovations in any sorts of therapy is always a step forward, but we just need to validate it in the context of how it's been given and also the expertise it's given with.
Thank you. No, just building on that, it was actually on a BBC News report came out of the Times, and it was saying it's on the NHS in Cambridge, which is very interesting. Yeah, it's in Adam.
Absolutely. So there's also accessibility of where you are nationally for such treatments, and you know, we were talking about lymphedema, and there's lymphosurgery available for in various regions depending on the availability of the surgeons who can actually do the procedure. We have, you know, access to microbeads and liver ablations that will locally, both with chemotherapy or radioactive beads. So there's all sorts of techniques for liver ablation, be it internally or systemically. So no one fits. There's no exact perfect treatment for all types of liver disease. It's going to be a combination of the tumour phenotype, whether it actually matters, whether you're ablating one area in the liver when everything else needs to be dealt with. So do you need something that's more whole body or focal? And if it is focal, you want something liver-based. What's your local expertise? What's the opinion of the specialists that look after you? And where can you get it? And is it possible for you? Because if you have several segments of the liver involved, something very ablative or damaging to normal liver tissue is not going to be feasible, whereas if you have a localized area, those kind of treatments are going to be feasible. So it's all in the context, but always happy to see innovation. Yeah. It's always good.
And just to mention very quickly, it's really important to have a conversation with your oncologist, because when it comes to the media, they don't explain things. So for example, we've had 2 new drugs in breast cancer, metastatic breast cancer, announced recently. One of them is elacestrant, and the other is capivasertib. And they didn't say how you get it or when you get it. And I had patients ringing in every time to ask about this new wonder drug. But then if you're HER2-positive breast cancer, you don't get this drug. If you've had multiple lines of treatment, you don't get this drug. If you don't have the biomarker for this drug, you don't get it, but it doesn't say that in the news release. So you just have patients really ringing up. So it's important to have that conversation with your oncologist.
So I'm going to take some questions live. So I'm going to pick up the tempo a little bit. So let's try to keep our response a bit brief, just get through lots of questions. So I'm going to do 2 to Jill. It's a 2-header. So the first question is, what exciting non-drug treatments are around or coming around? I was just thinking exercise as a non-drug treatment, but what do you think?
So exciting, so
non-drug.
Non-drug. So for me, it's radiotherapy fractionation changes in terms of reducing the amount of radiation, either completely, so studies like Supremo showing that we may not need to give radiotherapy.
That's in early breast cancer.
In early breast cancer, yeah. But also in that for treating chest wall nodes and so on, that we can give shorter fractionation. The other thing, I suppose, is it's not really much about it at present, but using non-chemotherapy radiation-related drugs to treat things like bone metastases and so on. And what else can I think of?
Exercise.
Second?
So I haven't read the New England Journal paper yet, though. Have you read it?
What, the colorectal
The exercise,
one? Yeah. Colorectal, yeah.
So exercise is a new buzzword in oncology at the moment. There was a New England Journal paper published last week, which showed outstanding data regarding reducing risks of relapse and prolonged survival. So, but this is in colorectal cancer.
And in early disease.
So, but this is something that you saw Catherine yesterday talking about exercise in breast cancer, and that's something that the data is a bit mixed, and certainly we need to do more research in breast cancer looking at this, because this is something that everyone can do to some degree all the time. be it in the early or secondary setting.
The other point to make is that the non-drug studies, I mean, Catherine, for those who were in the room yesterday, talked about exercise studies. They're really difficult to do and get funded because there's not a lot of money behind them, and we have to go, Catherine has to go to charitable funds or to government funds. Pharma doesn't fund it particularly. If exercise was a drug, we'd be doing lots of studies. So the other message to the ladies in the room is when you think about trials, don't just think about drug trials. You should ask, are there quality of life studies you can go into? Are there exercise studies? Lesley does a lot of psychosocial research. So ask about other things besides drugs, because most people can go into those studies.
And drugs and technology are sexy. You know, that's what.
And we've had sex here as well.
I bet you won't hear as much about exercise because people don't think it's particularly sexy in terms of a topic, and it's actually often relatively harder to do that.
Very hard.
I bet you it'll get far less airtime, even though it will be applicable to more people with breast cancer and other cancers, and it might have a bigger impact.
Yeah.
Can I just add?
Yeah.
So I've been living, as I said yesterday, with metastatic breast cancer for 11 years. And as well as a lot of luck and the drugs and a good team, I think exercising and staying active throughout that period has really helped. I'm absolutely convinced
Donna.
of it.
Sorry, can I just say as the fat gobby one? So I just think it's really difficult hearing about exercise and how it keeps you well, and it does, and it keeps you well, and it gets you fit for your treatments and everything. But I think it's very hard to sit and say to a patient, you know, if exercise is really good for you, it reduces your risk of recurrence. We're all sitting here now with recurrence, and you might be thinking it's my fault because I didn't exercise.
No.
It's not. You know, and I think that's like a big thing that, it keeps you fit, it keeps you well, it keeps all your organs going, it keeps you fit to get your treatments that are saving your lives.
And there's studies going around in metastatic disease as well, so the issues are exercise studies in metastatic disease.
But I think in the primary care setting, we pushed about, you know, exercise. There was loads of money put into exercise and meeting a personal trainer, you know, who would prevent you getting your breast cancer again. You didn't take that up, you got your breast cancer. No, it didn't. It doesn't work like that. I'm going to take
one more question online, then open it up, because it's a sort of link about drugs. So the question essentially, it's a long question, essentially is about schedule, dose reductions, and lengthening sometimes the schedule. So often we give treatments every 3 weeks, or for CDK4, 6, 3 and 1. So the question is about the potential detriment or not of dose reductions and lengthening the space between cycles. I'm going to do Marina, Bookie, and then take the patient's perspective with Lesley. So Marina first, and then Bookie.
Okay, so I think we discussed this yesterday. All our drug therapies are based on maximum tolerated dose. That's how all the phase 1 studies are designed. So we're looking at the highest dose we can possibly give without causing too much harm, but still seeing a good effect. Now, we don't do it the other way. So we've got good data from tamoxifen, which you may have heard of, that low-dose tamoxifen at 5, 10 milligrams as opposed to the licensed 20 milligrams appears to be very effective. Can we do this with other therapies? I think we're going to have to look at real-world data, because often these drugs will not be funded by a pharmaceutical company because they don't want you to use less. And so we're probably going to have to look at this with real-world data and academic studies, because there are some drugs, such as Enhertu, which has a lot of side effects, and although very effective, we don't know how low we can go. So we try to go low as we can to make it as tolerable as possible. Well, we need to keep an eye on efficacy, how well it's working. So it's a difficult balance, because if something's working, you don't want to go too low, but you do have to find a middle road. Okay.
Yeah, so when it comes to metastatic disease or secondary breast cancer, I think the two things that are very important, quality of life and extending life, those are the most important things. And we've found out that when we're using targeted treatment, which is more and more what we're using now compared to chemotherapy, that actually reducing the drug most of the time does not affect the efficacy. However, there's a big change in the toxicity that we see. So there's a big move now that's looking into that. So there's something called Project Optima being funded by the FDA that's looking at this. Also, my project is coming out in a few months. I'll be asking everyone to do that questionnaire that's coming out, and this is on dose reduction. So you're hearing about it for the first time here. So you will be getting all of this. But it's really important when your oncologist talk to you about dose reduction or changing your schedule, it's usually because of the tolerability. It's really important that you want to continue with the treatment with less toxicity rather than have a high dose and not being able to get the treatment. So that's really important.
Lesley, from a patient perspective, you've suffered side effects from treatments. So what's your perspective when you're discussing either stopping or reducing doses? What's your experience?
Well, I was on a drug called Enhertu, which has some pretty nasty side effects. I was tolerating it fairly well, and then I started to get very, very, very breathless, and nobody had warned me about this side effect. And actually, it was just talking to Carlo, who said, I think you need to go and get that checked out. And I developed something called ILD, interstitial lung disease, quite a severe grade of it, which has been fatal in, I believe, in women. So I had to stop immediately. And I had tried to, because I'm pretty determined and I want to live as long as possible, I did ask if I could go back onto that drug on a lower dose, which I believe some people do, and to have just to be really closely monitored. But I was told no, it could be much more serious next time. So, and I've never had any other, in terms of treatments, I've never had a break in my treatment. I've been on treatment non-stop. Or one time I did have a break, I got brain mets, immediately went into my brain. So I just want to stay on a drug that will keep me well and alive for as long as possible.
Just to emphasise Marina's point is that when we develop these drugs, it's about how much we can give to patients. These were originally developed for leukemia based, the way we develop our drugs. So the other thing is that there's lots of evidence that you can use drugs safely without impairing that efficacy. So always talk to your oncologist. Never be frightened if they're discussing a dose reduction. If they're discussing a dose reduction, it's because you're having a side effect that's impacting your quality of life, the ability to go to work, pick up kids, look after a partner who might be ill, So it's normally a reason. So having that discussion. I'm going to open up to the lady on the floor.
Thank you. Possibly the wrong question to ask when we're here as secondary patients, but I'm just really interested in education around signs and symptoms of secondary breast cancer. I had a primary diagnosis, went through treatment, got the all clear, and at no point did anyone ever tell me about secondary breast cancer. I don't know what other people in the room's experience, but pretty much everyone I've spoken to with secondary breast cancer has the same kind of experience. It's often not talked about. Why can't signs and symptoms leaflets be embedded into primary pathways? Why can't it be standard that every patient finishes treatment gets? It maybe is in some trusts, but it's definitely not in my experience and in lots of others' experience. I think it's really important that we should be sharing this message widely, given the thousands of people who get primary diagnoses and then are cured or told they've got their life back. And I didn't know what secondary was until I got a phone call telling me I had it, which is a huge shock. I understand people are scared, you don't want to make people anxious, but I also feel you should be empowering patients to
absolutely.
Have that
So Joe
information.
Taylor and METUP have made a big issue about this quite rightly, and there's this infographics. So what's the view of Donna?
At your end of treatment, we arrange an end of treatment appointment with a breast care nurse. It's an hour. It's face-to-face, unless it was COVID, in which case it was a phone call. It's a very difficult time because you want them to congratulate you for finishing your treatment. No one ever says you're cured, but we say you're cured. You've either got it or you haven't, so you haven't got it. So, and you've done amazing. You've suffered through all your treatments. And then we have to go through a list of signs and symptoms, red flags. So that's what we do. And that is something that was...
I think it's changing. I think before, a lot of times people didn't really used to do that. I think it's starting to change. Even the conversation, I've had patients say to me, but no one ever told me the cancer could come back. Even that conversation is not had. But I think now it's getting different, and there are also a lot of websites you can go. So Breast Cancer Now has signs and symptoms of possible primaries. The other thing with signs and symptoms with secondary is that it can be very non-specific. So it's really hard. You can just be tired, and then you worry, you get an ache in your foot. You're thinking, could this be cancer coming back? So it could really be non-specific. But I think one of the things we say say is if it's persistent and it's not going away, please reach out.
I think the other thing is you can't do a one-size-fits-all, because as Donna says, people are receptive to that information at different times, and everyone here must have gone through consent forms for different bits of their treatment. Most of us blank out huge bits of it, even though we know we're about to go through that treatment. And I think it's a little bit like that if it's the wrong time, it may have been presented, but people put it to one side. Finding who wants it and when is difficult.
Do you want to come in?
I'll let Lesley.
Lesley?
It was just a quick point that as a charity, we've talked quite a lot about how to get that information out to patients, and it's incredibly difficult because you'd have to, you can have a nice leaflet, but then you have to go through so many layers to get that leaflet into a hospital.
But can I ask a question? I mean, when I see a patient with early breast cancer, the discussion is, I want to give you treatment to prevent relapse. So does that mean as doctors and nurses, we're not explaining why we're giving early breast cancer treatment? Because one of the conversations I have with patients, the reason I'm giving you this treatment is I want to stop the cancer coming back. If it spreads, it's not curable. So we are saying, or maybe we're not saying it's not been heard, and we need to change how we discuss that with patients. And maybe we need to reflect when we have those conversations. Maybe we say, at the end, I'm going to explain what it means to have secondary breast cancer, how to pick it up. So maybe it's on us that I discuss it with all adjuvant treatment, because that's the aim of adjuvant treatment. So maybe it's on us in the way we discuss it, and then when we exit the patient after that treatment, how we reinforce that again. What do you think, Jill?
So, firstly, I'm sorry that happened. From my point of view, any of you who have ever been my patients will know, I'm very clear about the reason I'm doing this is in order to prevent your cancer coming back. There is no certainty that I will do so, but that's the aim. And I'm quite explicit about it. And there is a degree of trying to be sensitive, but clear. The other thing is because we appreciate you have lives that do not involve us, which is just as it should be. But what I try to do when I'm saying I'm discharging a patient from routine follow-up is to say, I'm not planning to see you, however, this is where you need to go if you have symptoms that are persistent, specific, not usual for you. And I give them 3 choices. I say, you can use your breast care nurse, you can ring my secretary, or you can talk to your GP, but come and talk to us. And we'd rather you did that. The other thing is we're developing what we call PIFU, patient-initiated follow-up, which, rather than just saying, bye, off you go, is now becoming much more structured. So trying to put patients with different risks into different pathways, but always with the understanding that we may not be seeing you routinely, but there is a pathway back, and please use it.
Okay, I'm going to go back out to the audience. We're going to pick up the pace a little bit because we've got about 9 minutes left. I'm keen. We've got ladies to the left who will hang me if I don't get to them because they've been very patient. So, lady at the back, and then we're going to move to the left-hand table.
I'm not sure how this question is going to go down. The severity modifier.
Okay.
I feel like before, when we were classed as severe, our overall survival was creeping up because of the innovations and the drugs that you're able to see coming into the pipeline. And now we've been downgraded to moderately severe, and I feel like we're almost having a cap put on what our lives are worth and how high we're watching it creep up, and it's suddenly going to tail off because we're not getting the drugs that we need to keep living. And how do you all feel about that? And
so, to make the point that the severity modifier is in England only, not used in Scotland, and it was foisted upon us by NICE, and lots of us were arguing about it. We've got pharma colleagues who have to deal with NICE over this. Marina, I'm going to bring you on that. Severity modifier, what do you think? What can we do about it? Is it going to drag us backwards?
Thanks, Carlo, because this is really contentious.
I love you.
Sorry, Marina.
So I think it's a tricky one. I really do think it's a tricky one. So I think we're, as a group, as a body, in breast oncology, we need to work together, not only with the charities, but with pharma and NICE. We know that within the NHS there are huge restraints at the moment. We can see it in everyday practice, we can see it in primary care. But there are some drugs that make a huge difference. And how we get that across is with political skill. Now, I don't know where we are in terms of will it be discussed again.
It was being reviewed, and I'm not sure what's
I'm not sure where we are again.
I
don't know if you know.
very quiet. It's lost. Yeah, I think it was reviewed, and in fairness, we have had new drugs with it around. I mean, the main one has been, I don't want to say the word, I mean, the main one has been TDXD for HER2 low. That's been the biggest one.
That's what we're essentially talking about, aren't we? Yes. I think that's essential. So I think for the drugs that will affect much fewer women, the elexestrants, the capivasertibs, even with the genomic testing, will get through, and they'll continue to go through. But drugs that will have a huge, almost population difference in secondary breast cancer, they're going to struggle to get through. But I think we put pressure on both sides, both with pharma and with the government, and we work at both ends, and I'm still hoping we'll be able to get this through. I think we will. For some women, it won't be quick enough, but we need to use... I think we have an engaged government as well. I think with West Streeting, I think we have an interest in the cancer plan. I think we have an interest in moving cancer therapy forward. So we have opportunities, and I would not lose hope on this. I still think we can get this over and through to the patient population. I really do.
Lady in red, and then we're going to that table.
So just on that point, are you talking about working with NICE to change the severity modifier back to something more like it was
Yes,
before?
I think so,
because that's what we need.
I think that's what we do need,
I mean, there's been a lot of discussions on breast cancer now, and mixing cancer have also been involved. There's been vast discussions. I once had it explained to me, and my eyes almost bled. It is really difficult.
We're in a group that's also fighting this as well.
And that's really important you have your voice heard, but it's a very complicated model. I don't really understand it, and as far as I can see, for some drugs, it will never get stuff through because of the way the model works. But that's the key thing is, if you see something that you're not happy with, write in. You've got MPs, you can write to NICE directly.
Write your MP. Actually, it does make a difference.
You know, NICE, when they do consultation, it's open for everybody. So anybody can write in. You don't have to be linked to a charity. Any patient can write in as an individual. The ladies to my left have been really patient. So ladies to the left of me.
Hi, it's a very quick question. It's about a reduction of dosage of stuff like palbociclib. My question is, how low will you go?
Well, there are only 3 levels that you're allowed to go. So the drug palbociclib comes in 125, 100, and 75. So those are the 3 levels. However, in terms of the scheduling, a lot of patients we've had to modify it. So I have a patient who is on 3 weeks on and 2 weeks off, which is a 5-week. I have a patient who is on 2 weeks on, 2 weeks off. So there are a few modifications that you can do, especially when you get to the lowest. So it depends on you. It depends on what's going on. There are some trials that are looking into specifics, where you have a continuous dosing at a lower dose or those kind of changes. But I think your oncologist would speak to you about those.
Lady in blue.
So this is a little bit of a plug as much as a little bit of a question. We've heard about patients getting involved in trials as participants, but what we haven't really heard is about patients getting involved to help the researchers as representatives or advocates, as sometimes we're called. So myself, Lesley, a number of other people in the room are part of Independent Cancer Patient Voice, and there's lots and lots of ways you can take your patient experience through charities like Breast Cancer Now, Cancer Research UK, directly through universities, your health board, all sorts of ways. So if anybody is feeling that they want to help in that way to help shape the research, because it's for us after all, there's lots of ways to get involved.
Absolutely.
But as clinicians, how useful have you found it to work with us, and how has it actually helped you to improve what you're delivering to the patient at the end of the journey?
Well, can I even broaden it out? There was a comment earlier about trying to get different skin colours for radiotherapy. We're trying to do the same with different body sizes and skin colours for reconstruction. I think anything that people are prepared to do in terms of education, providing pictures of their reconstruction, their skin mets, it does make a difference, and it all helps for, unfortunately, other people that are going to go through this journey at a different point.
And funders now, if you don't have patient involvement, you don't stand a snowflake's chance in hell of getting your application funded. It's in everything I can think of where I would want to get money from. They ask me, what is your PPI involvement? What patient's been involved? How they've been involved? How they informed your research? have you asked the patients about the research and their views? And they often want a letter from a patient and some sort of data saying, is it acceptable patients? And then how are you going to make sure that your population that's going into the study is going to be diverse and represent the women and men living with that cancer in the UK? So that the funding bodies now are really, really hot. And you can't, if you haven't got PPI, just step away, because you ain't going to get that money. So actually, and the other thing is that it's not lip service. Some of my colleagues, and seen other places, they get somebody on, they get a PPI person involved, and then they forget about them when they start working trial. And I've worked very closely with Lesley in projects. You know, you provide a perspective that is really valuable, that means that we don't waste money doing things that won't work because you ladies won't go on the study. It's
Carlo,
invaluable.
can I just quickly add that I think, because we're almost out of time, so the way I got started was with my local hospital, and they had we're looking for patients, and I think I contacted one of the nurses there to ask, how can I get a bit more involved? So I wanted to learn more, and that's how I got started. I think everybody here probably, if you're interested, that's maybe an initial step into it, and then you just start to learn more and have more experiences, and carry on and get involved in many more things.
So I'm going to take some quick fire questions. I'm going to allow another 2 or 3 minutes, just in respect of the colleagues of patients online who've been waiting patiently for their question. I'm going to take a couple. So on some quick fire questions. I'm going to take one of you at a time. So first one's going to be to Marina. The tumour's got both ductal and lobular subtypes. Does it make a difference to treatment?
No, but it may make a difference. Sorry, I forgot to raise my arm. Often it doesn't make a difference to treatment. It may make a difference to presentation and the imaging that we use. But essentially, all the therapies in all the phenotypes are the same.
So question
for now.
Thanks. Question to Jill. A lady's got ER positive, HER2 negative, lobular PIK3CA mutation. She's got Mets in the bone, the liver. She's on second-line treatment. She's not had the Mets biopsied. Should she be worried?
She's not had
the Mets biopsied. Should she be worried, or should she have been biopsied?
I personally would try and biopsy because the receptors may have changed. Would I be worried? Not necessarily if she were responding to treatment and tolerating it.
There's a quick question about progesterone receptor positive cancers. Do we test for it, and what do we do with it? Bookie, very briefly. PR positive cancers.
Yeah, so we do test for PR, but it's not across. So because we do know that the estrogen carries most of the hormone receptor part of the treatment. So that's what we ideally look for. However, in some trust, you do check for all three. If you're on a clinical trial, we want to know all three. But it doesn't really change. Sometimes it's helpful for prognostic, meaning that you want to know how the cancer might behave. So if a cancer has both ER positive and PR positive, they might do better than those that have only ER positive and PR negative. So it's more prognostic than for treatment. But for treatment, it's the ER that carries the most benefit.
So I'm going to take 2 more questions really quickly. So a question, the lady's got 2 very small bone lesions. She's been told she's oligometastatic. She's been stable for a long time. Could she ever be told she could be cured? When would we use that word? Who wants to take that one? Marina.
What breast phenotype?
She hasn't put that. She just said stable. Four oligomets, 4 mets, stable a long time. Do we ever use the word cure?
Yeah, so I think at some point, and I don't think we've quite reached it yet, there will be women who will be cured of their metastatic disease. This is something that's been discussed very tentatively in the oncology meetings. And that's because, I suppose, would have called them the exceptional responders, women who had their first treatment and everything disappeared and nothing seemed to happen for years afterwards, but they still continued their therapy. I think tentatively, after 3 years or 5 years, some clinicians are recommending stopping treatment, be it hormone therapy, Phesgo, or something else. But we're still, I think, hesitant to say cure because we still like to do follow-up scans and we still like to double-check. But I think that's a reality. Yeah. I think that is going to be what potentially something we can do.
Final question to Jill. Just the last one about radiotherapy, just because we haven't had a radiotherapy question, then we're going to close it, because I just want to, there'll only be one question I haven't taken. Palliative radiotherapy to the spine for pain relief, how often can you give it to the same area? Part 2 is, pain from cord compression and mets in the spine, how do you tell the difference? Briefly. Okay. So how many...
So how often can I give it? That depends what I've treated, what's in the way. Some tissues are more sensitive to the others. So, for example, I might irradiate skin more times than I'll irradiate bone, spinal bone where there's cord underneath. We do the calculations to try and work out, in effect, an equivalent biological dose. And sometimes there's a discussion with the patient about the risks of re-irradiating where you have no other option. So that's that bit.
Okay. And the difference between pain from a bone met from cord compression?
Okay, so pain from a bone met may be combined with pain from cord compression, but cord compression classically, you have neurological type pain, so we talk about girdle pain, toothache, burning, altered sensation. But you can get that still with a spinal bone met if it's just compressing nerve rather than cord.
Okay. Can we thank our panel?